to the second round of our community conversations here at AMTA. We're excited to be with you tonight and share this really important information. So as we get started, we're going to be providing a great bit of knowledge and resources and things like that this evening. So please make sure you're watching the chats as we talk with you all. And we're also going to be providing a link to the resources that we provide tonight so that you can access them after the webinar. In addition to that, this is being recorded. So we will place the recording on the AMTA YouTube channel when we're finished. So again, welcome everyone, and we're excited to have you here with us. To get started, I'm going to introduce everyone, and I'll start by introducing myself. My name is Lori Gooding, and I am a president-elect of AMTA and chair of the COVID-19 task force. So it's great to be with you. And as we set you up for the information that we're going to provide, I'm going to talk to you a little bit about how the task force is structured and also introduce you to everyone. Right? So the task force was created just over a year ago. It was March 18th that the board of directors approved the creation of the task force. And our purpose is really to support the music therapy community, both in AMTA and then outside of AMTA. And so we really focus on trying to provide resources, provide information, and collaborate with as many music therapy community stakeholders as possible to make sure that you are getting the information that you need. And you're going to see that tonight in some of the guests that we have joining us who are not regular members of the task force, although at this point honorary ones. And we're going to pull them in to give you some information that we needed some expertise on. Right. So I'm going to take a moment now. I'm going to share screen, and I am going to introduce you to all of our AMTA COVID-19 task force members. So here you see in the members, you see Seneca Block, and you'll get a chance to meet each of these later, and they'll introduce themselves again as they do individual segments. We have Seneca, who works in healthcare, Andrea Dalton, who is working in trauma-informed care, Barb Els, who works in everything and keeps us in line and full of information. She's a consultant for AMTA. And then, of course, me, I am a faculty member at Florida State University. We also have David Knott, who also works in healthcare in pediatrics. Rochelle Morgan is unable to be with us here tonight, but you were able to see her on the screen as you were coming in. One of the songs that Andrea played for you all was Rochelle's and her employees. She's a music therapy business owner, and she really keeps us connected in with the MTBO community. And then we have Heather Wagner, who is another faculty member and also a practicing clinician in the Northeast / Mid-Atlantic region. So we're, again, really happy to be with you all tonight and share some of the information that we have connected and collaborated with others on, and also coordinated in order to be able to release it with you all. So I'm going to bring in our first panelist tonight, and that's Andrea Dalton. And Andrea is going to talk to us a little bit about hot topics, of which there are many, I'm sure, but she's going to share some great information. So thank you, Andrea.
Thanks, Lori. Yeah, there are a lot of hot topics right now. I think one of them that we've been taking a good look at is vaccines. So I'm going to talk about that just a little bit, and infection control to kind of start off this section. A lot has changed with vaccine access, even in the last few weeks. We did this webinar, a different version of this webinar a few weeks ago, and even in that short amount of time, a lot has really changed. More eligibility tiers are opening up in different states, and availability of vaccines has increased. The federal administration has a goal to get everyone who wants a vaccine access to it by the end of May, which I think is really encouraging. They've also put out that they're working to decrease the inequities that have existed in the rollout so far. And I think that that's really encouraging also. Access to vaccines, though, does continue to vary from state to state, from city to city, at different levels. So if you want to be vaccinated and haven't yet had access to it, the first step is probably to consult your local health department. You can also check out, NPR had put together a locator tool, and that link will be In a document that David's going to share in the chat, we have a long list of links because we have so many, so many resources are out there. We have a long list of links. We're going to pull out a few, but that locator tool for vaccine access is one of those in that document. Remember, of course, that music therapists are health providers. And so I would encourage you, if you have not been able to get access to a vaccine because you haven't been considered a health provider for some reason, AMTA does have a letter on our COVID resource page that states that music therapists are essential healthcare workers, and that letter supports kind of our prime access to vaccinations. And I do want to say, vaccination is a personal choice, and there are a lot of factors to consider in that. So we recommend talking with your primary care physician as you make that decision for yourself and for your family. And if you do choose to get the vaccine, just keep in mind that the highest levels of immunity aren't developed until a couple weeks after you receive the second dose, if you get the Pfizer or the Moderna. And the guidance from the CDC is to continue masking and social distancing during that time. The CDC has updated guidance on gathering for people who are fully vaccinated. I'd like to just remind you that that is like general guidance for your personal interactions, and I recommend consulting the CDC's guidance that's really specific to healthcare professionals and infection control for your work. And David's going to drop the link for that one in the chat. That particular one, again, is just really specific for healthcare and working with various, potentially vulnerable populations. So a couple of other considerations for the vaccine. Many people have had side effects strong enough to take them out of work for a day or two, particularly after the second dose, but some after the first dose as well. So you might wish to consider how you schedule getting your vaccination in order to allow time to manage those side effects. Some potential or expected side effects are linked, I think, also in that big document that we are sharing tonight. It's also been identified that using pain relievers like Tylenol or Advil prior to receiving your vaccine dose might blunt immune response. So if you ordinarily take pain relievers like that for other reasons or on a regular basis, you definitely want to consult either with the provider at the vaccine clinic or perhaps your own primary care physician in order to determine what you ought to do. Because again, that's very personal and individualized depending on your own health status. So, and then finally, just one other thing about vaccines. There is a lot of discussion happening right now around whether or not an employer can require you to get a COVID-19 vaccination. And interestingly enough, I have read legal opinions from attorneys that know a lot about law that say both things, that one of them said you can require, one of them said you shouldn't. So I think the best advice probably is, keep aware of that. I think particularly if you're a music therapy business owner, you might want to recommend speaking with an employment attorney who's familiar with your state laws if you are considering requiring vaccination for your employees. And again, that's a choice that you have to make. There's a lot of factors that might roll into that. And also keep in mind that there are always exemptions mandated by federal and state laws as well. And I think the discussion around mandating vaccines certainly extends into how businesses and event spaces might require documentation of vaccinations for entry. And again, I think this is just something we're going to have to kind of keep in our awareness, be paying a lot of attention to. There will undoubtedly be decisions to make about whether or not you disclose your own vaccination status, if and how to request vaccination status of your patients and their families. Again, there's just a lot to consider. We're actually going to touch on the many, many decisions that have to be made along the way in just a little bit. Kind of along a similar vein with vaccinations is infection control and prevention, and particularly cleaning of instruments. And we asked for some questions to come in ahead of time. And one of the questions that was asked was about cleaning wooden instruments. And David's going to drop in the chat a link to the NFHS instrument cleaning guidelines. And then in that big document, there is also a really comprehensive guide to cleaning instruments from the Eastman Music Company. And I think the general guidance right now for music therapists is probably consider, if you can, or as much as you can, eliminating wooden instruments if you haven't already, or only use them if they have a really thick impermeable layer of lacquer, and that can be fully cleaned and disinfected. The solution to clean instruments, of course, is going to be damaging, and particularly if you're doing that a lot over time, interacting with a lot of different people, that potential is there. And you may not be able to sufficiently disinfect more porous surfaces, certainly. So kind of related to that, another question came in about sensitivity to cleaning solutions. And you might just consider looking at what is available. If you work in a facility, connect with your infection control department. If you have some sensitivities to various elements of those cleaning solutions. There are a couple of links in the document we're going to share. You may also have to consider in the area that you work, if you are the one cleaning those instruments or if there's someone else who does that, and then if there's wait time before you are there to kind of let the fumes dissipate. And certainly with any products that you use, it's always recommended that you follow the label instructions, especially for like how long the surface must remain wet in order to be fully disinfected and other warnings that might be there. And of course, with things like vaccinations and infection control and everything else, there's a lot of unknowns. And I think particularly with the newer variants of the coronavirus, which Barb will talk about just a bit later, and vaccine effectiveness. And there are still vaccines that are not approved for use in the US, but have been in other countries. And, we're kind of keeping an eye on that. There are some vaccine trials underway for children. And there's definitely a push to get back to normal. I think we're all feeling that right now. Like, we just want to get back to normal. But I think we probably still have quite a ways to go before we're going to be at like herd immunity levels and at a point where we won't need to mask and social distance in kind of general public areas.
So Andrea, given all of these hot topics, and a lot of them are pretty significant sources of stress, you as a trauma-informed care instructor at your employment, at your job, I'm wondering if you're seeing any differences about stress or coping among caregivers and staff, and now that we are a year into this pandemic.
Yeah, I mean, I think the short answer is yes, of course. It has been and continues to be a difficult and challenging time. And even with things beginning to open up more, things are always shifting, right? It's life, it's the world. And yet right now, I think we're kind of at an uneven time, sort of, where people are excited and happy that things are opening up a bit more. And yet at the same time, we still have so much change. We have so much loss to mourn and manage. And I think for many of us, we have been sort of running on adrenaline for a while, like just to kind of keep our heads above water. And at some point, I think for most of us, that may have already worn off. We may have already hit the wall. And then we kind of get we might sort of get that renewed energy or, another kick of adrenaline, and it kind of keeps us going again for a little while. And then we hit another wall. And right now, we're about at the 1 year mark. And so we might be experiencing a really broad range of anniversary reactions, remembering, what it was like to have our kids home for spring break and then not go back for in-person classes the rest of the school year. Getting phone call after phone call from contracts saying that they're putting your services on hold realizing that it's been more than a year since you saw your parents or your grandparents, or like for me, I didn't get to see my grandmother one last time before she passed this winter. And, I think when we get to that 1 year mark, we start to think back a lot over those things that have happened. That can become really overwhelming. I think there are also opportunities at that 1 year mark where we do kind of reflect back and think about like, wow, look at how much we have overcome and how much we have learned at this point. And so again, there's just that wide range of reactions that we might have. And then I think there's like things like guilt and shame that start to creep in too. Particularly if we've had it, a little easier maybe during this time. So, again, being at this 1 year mark, I think it's important to acknowledge that anniversary and to acknowledge the losses and kind of think about how we navigate that. And so fortunately, our colleague Heather on this call and Lauren DeMeo, along with Molly Hicks, whoever I just mentioned is someone else. Molly Hicks put together a video which premiered Monday evening, and it's on the AMTA YouTube channel, to provide some support for managing grief and loss associated with this 1 year mark, and just to pause and acknowledge the many losses in this last year. So thank you to Heather and Lauren and Molly for doing that. Just another couple things about this. I think because of a variety of factors, including systemic inequities in our culture, some people definitely have been more impacted than others, and I kind of alluded to that a minute ago. And we are also starting to see, or have been already seeing, elevated needs for mental health care. And we anticipate that those needs are going to continue probably for years post-pandemic. And I think a lot of people would say we were already in a mental health crisis even before 2020. And the healthcare and social service workforce in particular has been really impacted this last year. And our students also have been really impacted. Again, there's deep concern too for our patients and our service users who have been and continue to be more isolated. And there's just so many layers of stress and trauma, directly and indirectly related to COVID-19. And as a task force, then we are really committed to continue looking at gathering and developing resources to help our music therapy community, both as we respond in our communities and as we manage experiences like caregiver and compassion fatigue and moral injury. So I just want to really encourage everyone to please reach out if you need support. It is a really difficult time and continues to be a really difficult time. And we're unfortunately far from over, and we need each other. We do. And I think anybody on this task force would be willing to talk with anyone who needs some support. You can, reach out within your own circles as well. And if you need any additional support, there's also the disaster distress helpline that is part of the pandemic response from the Substance Abuse and Mental Health Services Administration. And I think David has the phone number for that he's going to put in the chat. And you can reach that disaster distress helpline at 1-800-985-5990. And that's available 24 hours a day. So thank you, David, for posting all those things in the chat. And thank you, Lori.
You're welcome, Andrea. Andrea, let me jump in real quickly before we pass it on to Heather, because I just want to say a couple of things. I see some questions coming in the chat, and please know that we are watching those. We're going to have time to address the questions at the end. So feel free to put your questions there if you have any, and we will address them. And then I also wanted to just point out, I dropped the link for our COVID-19 task force web pages through AMTA. And on the front page on the landing page for the task force resources are contact points for us as a committee, but are a task force, and then also for staff at AMTA. So if you need some additional support, like Andrea is talking about, please know you can go to that page and get contact information really quickly and easily.
Yep. Thank you. So now we're going to pass it over to Heather, who's going to talk a little bit more about some of that clinical decision-making stuff that I mentioned, as well as singing and masking and all of those kinds of topics. So
Yes.
Heather?
Thank you. Thank you, Andrew. That's really helpful information and just some really wonderful things that we all need to keep in mind as we do the best work that we can for each other. So when we think about, our clinical practice, we've all been dealing with a lot of changes when from being very restrictive, and as things are evolving and we're eager to get back to our standard of care, there are things that we can perhaps keep in mind that we can do more fully than we could before, but still lots of considerations in that way. So I just want to present this to you first. In thinking about this model, the Swiss cheese model is what they call it for trying to mitigate risk, is that there isn't one particular thing that will be a 100% foolproof for disease transmission. So we think about these as all these different layers of Swiss cheese, which each one has holes in different places. And the more layers of cheese that we stack on top of each other, the more the holes get blocked. So when we think about mitigating risk, think about where your holes are and what other precautions may you need to take to close those holes, and that not one will be sufficient long term. So it's a great little graphic. You can Google Swiss cheese model for pandemic and it will come right up. But when we think about sorry, let me get back to slides. There we go. Our mitigation strategies, right? So far it's been pretty well understood by all of us for the past year, the need for social distancing, which the recommendation is pretty much solid at the 6 feet, that we have the physical space in which we find ourselves. So a lot of this has to do with how we the room ventilation and being sure that there is sufficient air return so that we can clear the air in the spaces in which we are working, and of course masks. So another quick word about the physical space in which we work is thinking about that ventilation. Depending on where you work, there are many ways to help with this. So one easy one that's always recommended is if you could open windows. It depends obviously in the setting in which you work and in the weather that you find yourself in. Now you may be getting into pollen season, so all of those things you'll have to keep in mind. But one thing that is possible that has found to be highly effective is the use of HEPA air purifiers. Just being sure that if you do decide to purchase an air purifier for your space or the spaces that you are working, that it is sufficient for the room in which you are working, and that you also change the filter as recommended. So that can be a really effective way at clearing the air on a regular basis. Those of us who are fortunate enough to work in medical settings, for example, they do have a higher standard of air filtration, and so that can be very helpful. But if you're working in a school, for example, some of those areas, especially the older schools, are not very well ventilated, and opening windows has been one of the biggest recommendations that I've seen for schools. So be mindful of that, because that also plays into what I'll get into a moment of how long you spend in spaces making music. So, oh, sorry, I got a little bit ahead of myself here, but the 6 feet distance is still holding at this time. I don't know if anybody's playing trombone in their clinical practice, but if you are, they're actually recommending 9 feet. I see Lori got excited about that one. So any of you trombone players, or if you're using them with their clients, they're recommending 9 feet just because of the shape of the instrument. But other than that, 6 feet tends to be the accepted recommendation. And I did talk about the HEPA air purification. So when we think about masks, obviously we know the purpose of the mask is to limit the amount of aerosol spread, so limit the droplet and aerosol spread. We know there are 3 basic kinds. So there's the N95 and I didn't bring my little, last time we did this, I had on my little mask, but I want to move this a little quicker. So the N95, which we're probably all familiar with, which are typically worn by healthcare workers, and those tend to be really snug, and they can be fit tested to really cut down on air, but they are really difficult to sing in. I will say it's a little harder to keep the airflow for obvious reasons. But truly, the research that has been done on singing and droplet precautions all use just standard surgical masks. Yes, which David has on, if you can see him in the corner. Why, he's in my corner over there, right? And notice it fits very well. There are no gaps, and it's over his nose. It's just what we like to see. And those really are standard practice, and they really are sufficient for our purposes as music therapists. You can also wear cotton masks. The recommendation is at least double layer. And in fact, the best thing is if you can triple layer, if you have the cotton mask where you can put one of the little filters in, those are highly recommended. And even consider double masking so that, again, Swiss cheese, right? That if there's any sort of a gap, that we're covering as much as possible with the double mask. I personally use the 3-layer mask depending on where I'm working, and I double mask if I'm wearing surgical masks. And I find it to be quite accessible for singing. The N95s, when I was wearing those at one point, they've since eased that regulation at one of my facilities. That was a little more challenging, but I find the standard, even double surgical and triple cotton masks, to be quite, still to be able to be heard when I'm masked and singing. So, sorry, I keep losing there we go. So now let's talk a little more about singing here. So there has been a lot of questions like, are we allowed to sing? So let me first just say that being allowed to sing may be out of your decision. There are sites, and there are even people on our task force who know the science and yet still have been told that they are not allowed to sing in their sites. So you may be forced into this decision based on your facility. Even my university is still saying no singing in groups at my university. But the science does tell us, and you can advocate for yourself with the science, and there are some resources that are on the COVID-19 task force page that can help support this. But some things to consider are your volume. So this can be tricky if we're trying to socially distance and trying to have more space. So that you might consider some sort of amplification to help you with your voice so you're not projecting perhaps as much as you typically would, because the louder we sing, the more droplets that are produced. Similarly with our range, we're finding that the research is finding that higher ranges actually produce more droplets as well. And as you can imagine, diction, the way we are producing our sounds with our mouth. And of course, we can't, change all of our songs so that we're not making the puss sound, which is one of the ones that is more droplet producing. But keeping that in mind, I think particularly if you are working on speech and communication disorders, the kinds of sounds and what that means. And finally, projection, which is very similar to volume. How much are you pushing your sound out? And in those cases, some amplification may be very helpful. One very important, and this is based on the science from the last round of the study. So it's been a few months. It has not yet been updated, but we're still finding from that point, there's a recommendation of a 30-minute time limit of singing. Because what happens is the longer we sing and as our vocal cords warm up, the more droplets are produced. And similarly, if you are singing with other people, remember, if you're all masked, you have to make those decisions if that's safe enough, if enough of your Swiss cheese holes have been filled. If you are singing with others, of course, more droplets will be in the air potentially from more people. So that 30-minute time limit sort of what they found in the studies, that it seems like it's still an acceptable level of risk. And then the recommendation is then to clear the space long enough for at least one cycle of air to be turned over. I can't tell you how long that will be for each place you are. It depends on your facility. And that information may or may not be easy to find, but a general recommendation is a 30-minute break in between. So if possible, you may consider holding a group for 30 minutes, clearing that space, and if you can, another space, right? And then alternate through the day if possible. And finally, the recommendation is also to minimize movement with singing, because as we move around a room, we are carrying our droplets with us and then interacting with the other droplets in the air. So the more we can stay in our spaces, the more safe that is in terms of interacting, I'll use that word, interacting with other droplets. So now here's the big question. This is what we want to focus a little time on here is I've been vaccinated. Now what? So great, you've been vaccinated and you've achieved your immunity, you've been long enough. Does that mean we can go back to regular practice? Well, and forgive me because I'm going to be honest, since I can't see my notes, I might miss a couple of things, but hopefully I'll have it all here for you. But with our vaccinations and clinical work, what we know right now is if you are fully vaccinated, there are a few things that you can ease up on. And one is that if you've been exposed or if you have asymptomatic, or if you're if you're exposed and asymptomatic, there's actually no need for quarantine unless you have an underlying immunocompromising condition. We also have been still recommended for healthcare providers to continue to follow the CDC travel recommendations and requirements, which may be hard if you're like me and my family is in another state and I'm vaccinated and they're vaccinated. But because of the places in which I'm working, I'm still having to be mindful of whether or not I'm able to travel to visit my family. And if I do, I will have to take time off of work. And also to continue to follow current testing requirements. So again, depending on the facilities in which you work, you may be being tested regularly even when you're asymptomatic. For example, a lot of the nursing homes are requiring weekly tests. One of the nursing homes that I work in, even though I'm only there a few hours a week, I am lucky enough that they will allow me, they have me tested every week in order to maintain my presence there. One of the problems you may have is if you are in private practice, these tests cost money and there is funding for them, but whether or not your facility will support you also being tested as part of your ability to stay there, just to stay working there. So some recommendations for the CDC, you'll see a lot of them are still the same. So if you are vaccinated, there's still to still wear a well-fitted mask, particularly if you are with people who are unvaccinated or people who are at higher risk for complications if they are exposed to the COVID-19 virus, to continue your hand hygiene, to stay at least 6 feet from people with whom you do not live. So when you are in a clinical setting, these are people that you don't live with. So you still should maintain that 6 feet distance. Continued mindfulness of ventilation. On your own time in particular, still avoiding medium and large size in-person gatherings. So thinking about the fact that your personal behaviors will impact your work behaviors and thinking about the ethics behind that as well. Of course, getting tested if you're experiencing symptoms. They're saying for healthcare workers, even mild symptoms deserve a test. To follow the guidance issued by your individual employer, there may be specific things that your employers are asking for. And of course, there it is again, sorry about that, to follow CDC and health department travel requirements and recommendations. So what there have been recently, which many people are interested in because of working particularly in skilled nursing facilities, is that the Centers for Medicare and Medicaid Services just updated some guidance on March the 10th. So what they're calling, and this goes for, they're talking about visitation, but it also obviously relates to music therapy services. And I pulled this quote right from the website, is that facilities should allow responsible indoor visitation at all times and for all residents, regardless of vaccination status of the resident or visitor, unless certain scenarios arise that would limit visitation. So the scenarios that could arise is if there is an outbreak, obviously there will be changes. But they're also noting that indoor visitation should not be restricted as long as there is evidence that the transmission is contained to a single area. So if they do find a case of COVID and they're finding it's only in one space and it can be isolated, they're recommending that indoor visitation should not be restricted. So this really bodes well for music therapists being in healthcare facilities, particularly these skilled nursing facilities, because you should be able to be present in the same way. It is still recommended that outdoor visits are the best choice because of space and ventilation, but we know that's not always possible. So similar to that, compassionate care visits should be allowed at all times for any residents, regardless of the scenarios that may limit visitation. So even when there may be some cases of COVID, compassionate care visits are still should still be allowed. And interestingly, related to one of the conversations earlier, is that visitors cannot be required to be vaccinated. This is visitors, not healthcare providers, or to show proof of vaccination as a condition of visitation. So there is still some uncertainty about what will happen for healthcare providers. I know in Connecticut, there has been some talk of that, but nothing is official at this point. But that it's really important that no matter what, even if you're vaccinated and even if your clients are vaccinated, to continue to follow guidance as presented in the previous slide. So yes, we're more safe and we can be perhaps more present than we were before, but that we still should be following some of the same basic guidelines because we just don't know yet for sure how long the vaccination is, how long immunity is going to last. And for people who may be immunocompromised, we also need to be mindful that they are going to be more susceptible to complications from COVID. So the big message is that risk management, thinking again about how do you fill your Swiss cheese holes is balancing beneficence with maleficence, right? So what are the benefits of what I'm doing and how do they outweigh the possible dangers, right? The dangers of social isolation, the dangers of not providing services. And as we heard from Andrea, that's a very real risk when people have been isolated. So always keeping in mind what are our clients getting from what we're doing, and how can we mitigate that risk in a way that meets their needs but keeps everyone as safe as possible. And then I won't leave that big list up because David has that for you in our big list as well. So I'm going to stop sharing. And I know Andrea had a couple of questions to share with me. Let me just get rid of there.
Yeah, I want to call out one of the questions that just came across in the chat because
Great, thank you, because I can't see them.
Yeah, and I think it's a pretty, hopefully a fairly short answer. The question came from Melissa: if you have 60-minute sessions, does 30 minutes of singing with breaks in that session work? I mean, does that
I
fit?
don't know that I can say that definitively, right? Because I'm not an expert and I don't know that that's been studied, but I can tell you one thing that I try to do because I have some groups I have an hour group in one facility in a giant room. We are pretty well spaced, but we're not singing the entire time, and everyone is masked and we are very well social distanced. It is a huge room. So what we're trying to do is I'm doing some receptive music with some live music. I'm not singing loudly. Often it's a psychiatric facility. They're often not singing either. So this is my personal risk management mitigation. I feel comfortable with that level. But again, this is my personal comfort level and what we've agreed upon at the facility. So I feel like my Swiss cheese holes are filled well enough to feel comfortable, but you would have to make that choice for yourself. And I would consult with your facility as well to see their recommendations.
Yeah, I think that leads really well into another question, which, we've been kind of wrestling with on the task force, and I think is really relevant to everyone right now about, the fact that we do have this clinical decision making that we have to do every day, and it involves a lot of critical thinking and our judgment, our experience, the science, bringing all of that together. And I think it's interesting to think about, like, what kinds of situations are not so clear, and maybe what kinds of situations are there where we might have some exceptions to the current general guidance.
Well, I think the biggest thing to keep in mind is if you are particularly working with people who are in some way immunocompromised, that no matter if you're vaccinated and they're vaccinated, you have to take the highest level of precautions, because anyone who is at risk for having a more critical response to COVID-19, we need to treat as carefully as possible. So even if both of you still need to go to that highest level of precaution. We just don't know as well, even if they are vaccinated, how well the vaccination is protecting them at that point. So I personally err on the side of caution, but we have to look at our own practices and how they are impacting the work and how they impact our clients. Yeah, I wish there was a really easy answer and a really do this, but there's just not a very clear. You've got to take all that evidence and make the right decision for you and your situation. Yeah. Okay. Well, thank you. So this guidance that is evolving is really helpful for us as we put them together. But in addition to the evolving guidance, the virus is evolving. So that brings us to Barb, who is going to talk a little bit more about the COVID variants. So Barb, if you could just fill us in, we're grateful. Thank you.
To do that, let me just share screen here. So I'm just going to dive right into the variants, and this is an update. I know we have folks on the call that were with us a month ago, and there are updates to this topic. So I do want to start with a nerdy moment. Each coronavirus, each one, like in that slide, contains almost 30,000 letters of RNA. That genetic information allows the virus to infect cells and replicate. So sometimes there's a genetic copying error, kind of like a typo, and a mutation occurs. So to get through a little terminology here, many of these mutations are meaningless. They're clinically insignificant, but some are not. We need to be concerned, but we shouldn't freak out. That's not good, and it's not necessary. A group of coronaviruses that share the same inherited set of distinct mutations is called a variant. So this image, and I don't intend for you to read all the detail in it on the screen, was adapted from the Economist journal magazine, and it was presented as part of the American Public Health Association series on COVID. It shows the lineage of variants as a family tree, with the root of the pandemic at the top and several main branches that include the current variants of concern. And I'm going to come back to those current variants in a moment. It's perfectly normal for viruses like the corona family of viruses to experience these mutations. It's what RNA viruses do. They mutate more easily than DNA viruses, and a DNA virus would be something like a pox virus. On the right side of the slide is an image depicting the relative evolutionary speed of mutations comparing corona with influenza virus. As a point of reference, the flu virus evolves quite a bit quicker. While the SARS-CoV-2 virus doesn't mutate that fast, it's just transmitted a lot. It's more transmissible. How tightly the virus protein spikes bind to human cells correlates with the level of contagiousness, or its stickiness, to use a non-scientific term. Is it Scotch tape or is it Velcro in its stickiness? Some variants transmit and replicate much more efficiently than the native or root COVID virus. They're much more sticky. They're much more on the Velcro side of things. Whoops, I'm going to go back here one more time. So the higher transmission, it can lead to more cases of COVID-19 and a downstream strain on health resources, hospitalizations, and morbidity and mortality. But to remind all of us, and I quote Dr. Fauci of the NIH, viruses can't mutate if they can't replicate. Viruses can't mutate if they can't replicate. I'll ask Jane to put rhythm behind it. Viruses can't mutate if they can't replicate. All right. So since most mutations and many variants are harmless or go extinct, the CDC uses a classification system for variants for tracking and for raising attention on those that may merit more attention and may possibly down the road be targeted for an mRNA booster shot. The classification includes those of interest, those of concern, and variants of consequence. David, I did give him a link to CDC so that you can look those up yourself, and he'll post that and it'll be on our listing of links. But let's focus on variants of concern. In the last webinar a little over a month ago, I noted 3 variants of concern that are active in the US. B117 UK, B135, first identified in South Africa, and P1, first identified in Brazil. Since the last month, 2 more are on the list as a concern. Both were first identified in California of the B1 type, and 3 more are on the variants of interest, which means they're keeping an eye on them. 2 of them are in New York, and 1 is a P2 variant in Brazil. Makes sense, it's a P line since P1 originated or was first identified in Brazil. One of those New York variants is doubling time in the greater New York City area, and up where Heather's living is doubling much faster than some of the other variants. That may or may not be a significant thing. It's just an observation from the science. So I'm bringing back this image I showed you just a little bit earlier on the lineage of COVID-19. It did not even show one of the California variants when it was published, and that was only a little over a month ago. All the variants are on the list as a concern because they either have increased transmission capabilities, number 1, they're stickier, and or number 2, they have a higher likelihood of severe disease, and that's based on hospitalizations and case fatality rates. And or 3, there's a reduced impact on neutralization of emergency use authorization monoclonal antibody therapeutics. What that means is medications approved for emergency use aren't working as well. And or number 4, there's a reduced impact on neutralization by convalescent and post-vaccine sera. And that means response to vaccines and plasma from persons with antibodies post-recovery isn't working as well. Those are 4 key areas to consider, and harkens back to what Heather was talking about immune compromised folks and the antibody response. This slide simply shows the case spread of variants across the US between last month's snapshot that I took and this week's snapshot taken from the CDC site. Note the increased shading on the right, meaning more cases of variants are showing up in states like Colorado, Texas, Massachusetts, New Jersey, Georgia, Minnesota. And this snapshot of the map is for the UK variant, but you can select and filter on the variant of concern. I think all three, there may be more coming up soon, are on the CDC site. On the top are the actual numbers of cases and the number of states reporting. I calculated the increase in case and states reports all show well over doubling rates in a month's time. So these are active and on the move. There's no question about that. So this is a race to vaccinate and maintain precautions to mitigate or reduce transmission of variants, as well as the root COVID virus, and to do it prudently using our critical thinking and judgment. Continued masking right now is important because of some of these variants. Viruses can't mutate if they can't replicate. Thank you. The goal, according to epidemiologists, is to push towards 70% vaccination rate in the population. That moves to what Heather or someone referenced to herd immunity. But there's good progress over the last month, but there's a ways to go. And the president spoke today that we're recording this webinar on getting another goal for vaccination rates, double of what we just completed. We must remain vigilant, obviously, but there's good reason to be optimistic on the vaccine side for these variants, since boosters are easy to create, relatively speaking, and manufacture. And with that, I will pause and stop sharing.
Thank you, Barb. It's interesting to me how much it's changed even in the month since we last did this. It's fascinating. And yeah, and we'll leave it at that. But my question for you is thinking about these variations and these different strains. You know, I live in Connecticut and I work in New York, and so these are a real concern for me here. Do you have any way to predict, or what are your thoughts about how that may impact some of the guidance that we are currently having for singing and playing instruments that we know are there? What do you know about that, or what are you thinking?
Yeah, and you know, we did the grand rounds and invited Dr. James Weaver to talk to us about, and the recording is available on singing and instrument playing. And I want to remind everyone that that study focused only on the aerosol distribution. And so while you can get like 95% protection with the masking that Heather spoke about, there still could be aerosols that linger in the air. Mm-hmm. Now, if it's a stickier variant, you still need to maintain that distancing and be very careful, at least at this point in the pandemic. So I would err on the side of caution. There could be over time some advisories on it, although the more people get vaccinated, there are benefits to these vaccines against some of these variants. So even though I talked about those 4 criteria that they're looking at that puts them in a variant of concern, there still is some variant. But if you've got a high an immune compromised patient, Heather and I were talking the other day about solid organ transplant patients that you might be working with, they still need to have the protections, as do you, even if we're all vaccinated at this point in time. Yeah. So that study did not actually look at infection case rates around musical instrument playing. And I would caution folks to be careful. And I don't have the answer to Heather's question exactly, but it's something that requires ongoing vigilance.
Yes, it is hard to have clear answers with this, but thank you, Barb.
Well, thank you. Wrapped around safe music therapy practices and these tricky decisions that we have to make, and I see some great questions that are popping up, it's important to think about the topic of running sustainable practices. So Dr. Ed Kaler kindly joined us today to give us an update on PPP loans and related topics. If you look to the right of my desk, there's a pile of tax papers I'm working on madly. So take it away, Ed.
Thank you, Barb, and allow me to thank the Lori and the task force for inviting me to be a part of this event this evening. All right, yes, I'm going to talk a little bit about the PPP loans and where we're at from last year this time and what's currently going on with what they call the second draw, which is the second round of PPP loans. just to summarize, again, the PPP loans are for businesses, business owners, especially those who have less than 300 employees. The first round went out in the spring of 2020, and the second round, again, the second draw started in January of 21. The amount that one may receive, it's based upon your payroll. And in general, what they are doing is it's a maximum amount, about 2.5 times your average total monthly payroll that goes out. So that's how they're generally looking at how much you may receive in your PPP loan. Currently, for the first loan, and I would think the second loan is going to be the same thing, the forgiveness is 100% forgivable. The loan is 100% forgivable if you, again, follow the procedures and your guidelines and use those monies for payroll and other defined purposes, such as your mortgage interest for your business, rent, and utilities. So there are other things that it can be used for. One of the things I think is important, you're going to probably hear me say several times during this time, is reach out to your bank to help you determine whether you are eligible, and it can help you guide you through that process of looking at the eligibility for yourself and your business. Some of the things that we have learned and throughout the last 2 years, we actually have received the first draw and the second draw we just recently received for AMTA. But what we found is reach out to your bank and get that checklist. And that checklist will provide you things that you need to have prepared and the steps you need to follow to complete the application process. And I can't emphasize it enough to have that material available as you begin that application process, because you're gonna have to have it. And once you start it, they really don't want you to stop the application process online. So it's really beneficial to have all that information available at the time. Again, make sure your books are as clean, up to date as possible. Make sure you have the relevant payroll records, as I said. And when you receive the loan, one of the things we found very beneficial, and our bank even encouraged us to do this, and it was very, very nice. We started a separate account just for the PPP loan. So as that came in, it came into our bank, a different account. So as we made the payments, we can take it from that one account and then just make the payment. So it's a lot easier to deal with and handle when it's time to go for the forgiveness process and you have to pull all that information back together again. So where are we in 2021 compared to where we were last year in 2020? Well, it's my understanding that there's still some money for the first round. If you haven't received that, they're still taking some applications for the first round. I don't know how long that's going to last, and it may stop very shortly, but something to keep in mind there. The other thing to look at is you are eligible for a second draw if you can demonstrate a 25% decrease in a given receipts from one calendar quarter of 2019 to the same quarter in 2020. So they're looking at that 25% decrease from 19 into 20 in the same quarter period of both those years. The application process for the second draw ends on March 31st or until funds run out. And I have a certain comment about that right now. I want to make two comments that's not on the slides right now. In terms of applying for the second draw, it looks as though some of the banks are requiring borrowers to at least apply for the forgiveness of the first loan. That is not an SBA requirement, Small Business Administration requirement. It seems to be more of a bank requirement, the lender's requirement, than the SBA. So you certainly need to be aware of that. The application for the forgiveness has to be started and in place, but the forgiveness itself does not have to happen before you can apply for the second loan. And my second point is dealing with the third bullet point there. The original deadline was March 31st, and we just heard today, if you heard the good news, we are waiting on the House passed that they extended, the House passed to extend that deadline to the end of May. And just today, the Senate passed that. So now you have till May 31st to complete the application process for the second draw, which is good news. employees to make those applications. It was just that time period for that group of small businesses. Again, the eligibility for the PPP loan calculations has changed for the second draw. So I encourage you again to really make sure you're in contact with the bank as to what those expectations are, especially in terms of what you can expend on payroll and other expenses. Some interesting things that they've also changed with this one has to do with the folks who may have defaulted on their student loans. Previously, you were not eligible. This round, if you happen to default on your student loans, you now are eligible to apply for the second draft. And to my knowledge, and I checked with our accountant, the process for forgiveness for the second draw deadline has not been set up, and I've not even seen the application process for that to happen. So we're in a waiting period for that to be presented to us. So that's all I've got about the PPP loans, but I also want to talk a little bit about the Families First Coronavirus Response Act. And this is for the tax credit. So as Barb's preparing her big pile of taxes, we want to make sure that if you're self-employed, you make, if it's applicable, make those considerations for time that you might have lost because you were being quarantined, and for any care of children during that time. Be cognizant of the fact that sometimes the tax preparation software programs will not recognize this, and it may not show up as you go through that process on those in that software. So you may have to make those adjustments on your own. The good news, I think, too, is that if you probably heard this, that they've extended the federal tax return from April 15th to March 15th. So there's an extra month there. That's federal. I haven't seen many states picking up on that extension yet, but you need to keep track of what your state's requiring with state taxes, if your state has state taxes or not, income tax. And then finally, these are just some resources that I suspect will be part of the final documentation that you can certainly look at that may help with some financial program and some of your tax credit questions.
Good, thank you, Ed. You actually covered the questions I had on tax. And while you were speaking, Ed, there were a couple folks there were a couple links in our quest to not have any missing links that were put up there for folks to follow up on some of the information. I think we are also ready to welcome AMTA's Education and Training Programs Director, Jane Cregan, with us to give us some updates and comment on education and training during the pandemic. It's clear, Jane, that students and interns are challenged to get their pre-internship and internship hours completed around the pandemic. It's tricky and it's been difficult. The recent survey out to faculty and clinical supervisors confirms this, along with your update. We'd be interested in hearing, telling us about any adjustments permitted in training and internships that you can share with folks. Take it away, Jane.
Thank you, Barb. And also my thanks to Lori and the task force for inviting me to join this webinar. Both professional programs committees, and that would be the Academic Program Approval Committee and Association Internship Approval Committees, have provided guidance and continue to provide guidance to faculty and internship directors for clinical training. APAC has pointed out that there is flexibility in fulfilling hours for internship, as the standards for education and clinical training do not indicate a minimum of direct client contact time. Telehealth sessions can count for both pre-internship and internship hours. But it is important to note that when utilizing this practice, to be sure of compliance with permissions from both the university and the client's care center. Archived video sessions can count for pre-internship hours with specific tasks for student learning, such as analyzing music, collecting data related to objectives, identifying therapist resources, demonstrating implementation for clients, basically whatever would be appropriate to the level of the student viewing the session. Also, creating video presentations for groups, such as ones for seniors, focusing on music and movement, reminiscing, or singing. Pre-internship hours can be made up over the course of the student's time in the clinical training sequence of the degree program. Internship hours can also be extended if it doesn't result in hardship for the student. Also, both models of internship can be used to complete internship training. For example, in the event that a student was in a national roster site and it closed, or the training was interrupted in some way, interns can return to their home institution and do a university affiliated internship with new internship agreements, once new internship agreements are in place. Previously accrued hours would transfer, but the agreement for the hours may lead to some increased time depending upon the student's needs and abilities in relation to the time and tasks remaining at the new site. The internship committee is also fast tracking exceptions for such things as internship directors taking more students and internship director changes. The committee is also trying to expedite the reviews of new national roster applications. Both committees have worked directly with faculty and internship directors to provide assistance in individual situations with students that are not covered by the guidance. Also, keeping information flowing to faculty and students has been important. And so we have weekly clinical training and education updates. AMTA's Director of Communications, Jenny McAfee, and I started these updates last September. They are published every Friday and are sent out on all of AMTA's social media channels, as well as emailed directly to all AMTA faculty. The updates include new national roster programs, programs that are closing, change of internship director, change of the status of an internship program to either inactive or returning to active, sites that also update their information. It might be changing start dates or adding a stipend. And these updates come directly from the AMTA national roster. So as I update the database during the week, these are the changes that are reported in the education and clinical training updates every Friday. All of the updates for the past 7 months can also be found on the APAC committee page. We are currently tabulating the data from the clinical training survey and are coordinating with the faculty forum as well as key committees. We are speaking to the data next week on March 30th at the faculty forum meeting. One thing I noted from the survey was that faculty have relied heavily on telehealth for pre-internship clinical hours. Anecdotally, there appeared to be some unexpected benefits with telehealth pre-internship work, where students have been required to pre-record some of the music for their sessions. Benefits have been seen in the preparation quality for their sessions, in that students are better organized and the quality of the music is better because students are practicing more. On the other hand, there is exploration and research planning in the works, examining the extent to which there may be gaps in student readiness for internship because of the pandemic and shifts in education. And finally, I would like to make one plug for the importance of data collection. At this time of the year, I collect data from all faculty related to degree program enrollment and degrees granted. And these statistics are vital not only to the support of AMTA degree programs, but also to document changes, potential changes related to the pandemic, as well as assisting with research and predicting trends in the profession and assisting the work of the commission on the education and clinical training of the 21st century music therapists. These statistics will factor in as the commission comes to their recommendations for education and clinical training. So I look forward to receiving all of the data from all AMTA schools by the May 1st deadline.
Jane, thank you so much. And Ed, thank you as well for being our honored guest this evening. Jane, I just had a couple of quick questions. One, if faculty or students have questions, really individualized questions, who's the best person to reach out to? Would that be you?
It can be me. Typically, it is me, and then I will direct them to the professional programs committee. So students may come to me with a specific question. Sometimes I can answer it. Other times I will give them over to either the co-chairs of the committees or the committee reps.
Great, great. And just kind of picking your brain a little bit, what is one question that you keep answering on a repeated basis that you would just like people to know?
Actually, there have been a variety of questions. Probably, mostly are the things I went over at first, which are, what counts for clinical training? Faculty that, want real specifics about that, and some students that want clarification. So that's probably most of the questions. And again, referring back to the committees or, being able to help them with the information I have.
Yeah, great. Thank you so much for connecting with them and connecting them with the right committees to really help them too. I will also say that Heather is our regional president's representative for the board, and she's working with the regional presidents to make sure that your updates get out at the regional level too. So folks can get the information from both the national viewpoint and from the regional viewpoint as well.
I'd like to just make one more comment that, questions I get from students are basically letting students know what the resources are for them to access. Because many times, they're not aware. So I feel like I can make that, help them make those connections to either to the COVID website or specifically, to committee members, and that has also seemed to be helpful so that they're aware of the resources that they have at their disposal.
Yeah, and we appreciate that because we did see on the survey in the preliminary data that folks are using the resource pages from the task force. So that's really great. So we're thankful that you're sharing that and that people are getting the help that they need. So I think our next set of experts are David and Seneca. Guys, take it away.
Well, good evening, everyone. I'll take a minute and share my slides. But hello, my name is Seneca Block. I lead a large medical music therapy program in Cleveland, Ohio. And I am joined by David Knott. David, you want to hop in?
Sure. Hello, everyone. I'm David Knott. I'm the Creative Arts Therapy Supervisor and Music Therapist at Seattle Children's.
Cool. And can everybody see my screen? Yeah, great. All right, so we're going to talk about enhancing and expanding capability and some technology improvements. I'll go through a few software updates and then share some hardware examples about improving quality and ease of use. And then David's going to jump into some future developments. So really the gold standard in terms of software for telesessions has remained Zoom. This has really been adopted by several medical facilities and different organizations across the country. And another big point of that, though, is to remember that even though it is, commonplace to be using Zoom, it's also really important to make sure you allow for updates. I've been surprised at how many people I've worked with who just haven't hit that little update button. And it actually does make a pretty massive difference. In particular, there was a pretty big update that happened last fall that increases the audio codecs, that really eliminates audio compression, that really they actually created a music mode, a high fidelity music mode, which just allows the music to sound much better, especially if you're say using guitar and voice or whatever your instrument is in the room and you're using a condenser microphone. So that's really important. And then just some of the old standbys that I think have been outlined several times throughout the pandemic about really making sure that you use an Ethernet cable, being sure that, again, you have your Zoom updated. Another piece to mention is that be sure to check in with whatever your healthcare facilities or your general facilities rules are around that. And quite oftentimes they've already purchased licenses for that. So, continue to check in there. And the other thing too, I share that because it sounds like I hope people would have figured that out by now, but at the same time, those may adapt too. So for example, within our medical facilities over time, they just shifted to Zoom and everything opened up and it was fine to use a standard Zoom license until they implemented their own, which was a healthcare license. With that said, David's going to drop a link like it's hot in the chat about a successful telesession news release that just showcases one of our therapists using Zoom with a satellite unit with an actual COVID patient. So that kind of is just a good example of how Zoom can be used to reach patients in that time. So in terms of hardware, I just want to share just a few examples. I'm not sponsored by any of these brands. I just like them. So a few PC and laptop based tools. I'm just sharing the Apogee mic, which is a condensing USB mic. Apogee has really clean preamps and just gets a really nice sound. If you notice the sound of my voice right now, I am using a condenser mic, just to give a reference. You may notice when I get closer, it's a little more full. These are those sorts of mics. And then AKG just came out with a Lyra mic, which is really great too. The nice thing about them is if you're looking for a mic to use in this way, make sure that it has a input for your headphones, because you're then able to actually have some kind of control over what you're monitoring during that time. And then really quick, if you don't have a laptop or access to that, some more great tools just to use your phone, as a microphone. Shure makes a Motive MV88, which just plugs straight into your phone, has really great quality. And then Zoom also makes some really great products. Same as with the USB mics, you may want to look and make sure that they have an input for your headphones. Different models are different, but I am a big fan of the Zoom products as well. And again, these are just devices that you can use either with your smartphone, with your tablet, or on the other hand too, you could be having your students use these. They're more affordable, or you could have a client use these. Cool. And with that said, I am going to pass it over to David to talk about some of the browser music.
Terrific. Thanks, Seneca. That's a really great overview of the ways that you can use microphones and technology in telehealth sessions for live acoustic instruments. There's also the whole other world of just using everything online, and there's this kind of a scale of how much sophistication you want to approach that with. What I presented here are things that are pretty easy to get happening for yourself and for your clients and patients. The first thing is I put on my website a list of, it's sort of an aggregated list of a bunch of these things. I just wanted to give a couple of examples here. The first one is, well, there's Scratch. And we are really at a time of major development with these telehealth approaches, and some of these successes that we're seeing are very exciting to me, because it feels like it's one of the bright spots in all of this is learning new capabilities for music therapists, and I think that we're learning lessons now that we'll be able to apply for developing practice and reaching patients and clients that we would never even have the opportunity to see in person. So Scratch is something I learned about from attending the Western Regional Conference last weekend, and you might consider going to their website and go and registering for the conference. They're going to keep all those sessions up, or looking at conferences in your area, regional conferences, because there are a lot of things being presented on right now during this time. So Scratch was something that I learned about, and it is an amazing coding environment that is very simple. And in the course of the 1-hour presentation that was presented, they basically developed an interface that you would be able to have your client use the camera and be able to, when cued in a song, choose pieces of fruit on the screen and bring them into a basket. You could also change these things to where they make sounds when you touch them. It looked like there was an amazing amount of functionality with it. And, again, there is that little hurdle of learning how to use it. But, based on the way they were presenting it and kind of walking everyone through, I imagine that once you had the basics of it down, it would really be no more time than if you were preparing materials for any other kind of in-person intervention. So Scratch is something to check out. Something that's even easier than that are the resources that are available through the Chrome Music Lab. And I've put the link on here for the shared piano, which even that has a lot of functionality that you can change. You can show note names. You can play just using the keys on, or the client or patient can just use the keys on their computer. And you could think about how you can use these resources both within a session. So if you're focusing on specific goals within the session, you could look at auditory discrimination or facilitating basic engagement, or even increasing fine motor skills. You could also think of using these outside the session. So encouraging a parent to assist with practicing sequencing letters and having musical reinforcement. And then these can also serve as resources for independent use. So when patients or clients are discharging from music therapy, these can be additional resources that they can continue to use music outside of the music therapy time. So again, just maybe spend a little bit of time exploring these and see if you can have fun with these. I know for me, it's been a great source of joy and discovering new ways of making music and playing. So a little bit of plug for that. So thank you.
Okay. Thanks. Thank you, Seneca and David. I had a couple questions related to what they thought the silver linings were, but I actually think they kind of touched on them a little bit in talking about this innovation push that's taking place. To ask the obvious to Seneca or David, do you think telemusic therapy is here to stay?
I know I unmuted to nod my head, but I did.
Absolutely.
Mhm.
Absolutely.
Yeah, I think so too. Yeah. So let me pass it back over. We've been keeping an eye on questions in the Q&A and the chat, and I'll pass it over to Lori and Andrea in case she needs to unmute and talk about any of those questions.
Great. Yeah, thanks everyone, to all the panelists for this hugely helpful and important information you shared about so many areas. I hope everyone who attended tonight got some great information and got some helpful information. We're going to take just a second to address the questions, but I do want to just kind of make one broad statement, and you've heard us allude to this at different points this evening. Unfortunately, and with many of your questions and with many of the questions that we get on a regular basis, we can't give a definitive answer. Because the information is changing and individual facility policies, individual circumstances, whether, as Barb mentioned earlier, like you're working with a patient who's a organ transplant patient, or whether you're working with fully vaccinated, no immune compromised clients or patients, that the circumstances change. So in whatever we say, I just want to urge you to be cautious, to stay alert in terms of the updates with the information. We update regularly and do our best to get new information out as quickly as possible. But we also recognize that we are just providing you information so that you can make the best clinical decisions yourself using our information. And also using that ethical decision-making model that the ethics board has placed on the website, really looking at the information and then using that ethical decision model, or one of the models, is really going to be the best way for you to make the right decisions for you, your patients, the community, and so on. So guys, just thinking about the questions that came up, is there anything that anybody wants to? I know we've addressed a lot of them. And absolutely, Melissa asked about sharing the link, and so we can do that for the ethical decision-making model. We will plug that in.
And while we're pulling up that link, Melissa had asked earlier in the conversation about disinfectants, and that the question that came in on that with instruments, there were two actually. One was more of a standard question on sanitizing instruments, which I think Andrew responded to. And the other one was for therapists, music therapists who are very sensitive or becoming increasingly sensitive or allergic to peroxides, Clorox, that kind of thing. And the SanaWipe line is one that we have therapists in medical hospital facilities that are using this. This is the gray top SanaWipes. They have a longer drying time, but they're fragrance free. You still would need to be gloving up if you do have a true allergy to any of these chemicals. So I just wanted to mention that real quick.
And I also saw in the questions a question about sharing, or in relation to infection control, sharing instruments. I know from having worked in healthcare, many healthcare facilities have policies on sharing instruments anyway. So if you work in a facility, the first thing that I would urge you to do is talk to your infection control personnel, because many of the same precautions that you would use to share instruments outside of a pandemic are going to be applicable now. That said, if you do share them, there are certain, at least I know from the facilities I worked in, there are certain types of instruments that you don't share. There are certain patients that have patient dedicated instruments. And then there are certain procedures that you need to follow in terms of how much air, dry time, and that kind of thing after cleaning before they can be used again. So really looking at the infection control resources that we've shared, because they'll have a lot of that information in there, and then talking to those infection control personnel is going to be your best bet in making those decisions, because there's not a one size fits all. There are a lot of considerations.
And one thing I'll add to that is, as you're doing that, I would broach it and be open to planning how to do that with a group who hasn't done that before. And I say that because working across several medical facilities, some of the questions we brought to infection control, they just haven't done before. They didn't have answers before because they weren't used to developing a protocol specifically to new music therapy technology or for a particular instrument. So I'd be open to just, talking that out and knowing that you may have to write a policy with them that's new for your facility.
Were there other things that you guys wanted to highlight in the questions that came forward during our presentation?
Jen Hicks had a question about students being required to be vaccinated going to clinical training sites. And unfortunately, I don't have an answer for that. I have not been a part of any conversations about that yet. So I don't have any information, but certainly will check with faculty about that.
Yeah, I think that that's probably something that will happen in some areas and with some facilities, just like with any other vaccination. Some facilities require them and some don't.
Right.
And so I think this will be another one that we'll have to consider as we're finding placements for students. So something we're definitely going to keep an eye on.
Right, for sure.
Yes, and as I mentioned earlier, if there are definitive guidelines that are put out, we will absolutely share those as a task force.
The school's updated guidance on 3 feet distances in certain circumstances and not that's up in the CDC guidelines. And if you have any work in schools, obviously you should go be sure and check on that with your school district and the guideline with the CDC.
So thanks everyone again for both to our presenters and to our attendees. One last thing that we just want to remind you of, we mentioned a couple of different times, but to bring it home, so to speak, we have a resource list that's available, and David just dropped the link again. He seems to be dropping all kinds of things tonight. Next, he's going to walk out and drop that mic that's right next to him and end the show for us. So please make use of that. It has resources, a number of different resources that we have highlighted this evening for you to go and get the information after the fact. Continue to reach out to us, continue to send us questions. And if we are not the right group to address them, we will make sure they get to the right group. And then last, but most certainly not least, I just want to say thank you to everyone that you all are seeing on the screen. And they have been committing multiple hours and days and multiple aspects of knowledge and time and effort for the last year. And I cannot thank them enough. It is a pleasure to work with all of them. And it is a pleasure to serve the music therapy community together collectively and collaboratively. So we thank all of you, and we hope that you got great information tonight. Good night, everyone. Have a good evening.